This is the University of Michigan.
Founded as a place of universal learning.
To provide that gift of knowledge to all the citizens.
We wanted to study the world's problems
and solve them.
Dr. Salk administers the first official polio shot.
People came from all across the country,
around the world,
who wanted to fight for change.
How many of you are willing to work in the Foreign Service, spend your lives traveling around the world?
We said we were leaders, so we led.
Liftoff. We have liftoff.
We heard it was impossible,
and we gave it a try.
Everything we did
it as a team.
The team.
Together, we could accomplish great feats.
Beyond what any one person could do.
We are Michigan.
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 And after 200 years,
we can never forget why we're here.
To educate future leaders.
To advance knowledge.
To do good. That is our way forward.
Hello, my name is Lean Fellow. Today we will be talking about the vulnerabilities in the Medicare hospice program that affects the quality care and the program's integrity. Hospice care plays a vital role in the healthcare system, providing comfort and services that Medicare beneficiaries, their families, as well as their caregivers seek. Playing this significant part in the Medicare population, hospice has grown gradually over the past decade. In return, there has been plenty of vulnerabilities within these programs that have been reported to affect the quality of their care and their integrity. To better understand the growth of Medicare, we have to examine what exactly hospice is, why it exists, and when it was established. This will give us a better understanding of how it came about as a movement in the United States, as well as how it came about and what its functions are in Medicare. The Office of Inspector General report extensively details all the costs associated with the current status quo. The report goes into great lengths about how the costs of fraud and abuse affect honest providers, the beneficiaries involved, as well as the taxpayers. These findings will be analyzed throughout this excerpt, along with how financial management and population health relates to providers, costs, services, and financing affects the overall system. Hospice is simply not just beneficiaries and Medicare recipients. It is a program that deals with the negatives and positives of the healthcare system. Beneficiaries may not be receiving the proper care that they have been promised. The honest providers may have fallen into the trap of fraud. Taxpayers may be obliged to input more money into the system. Population health, financial management, and the long-tail theory are fundamental details to familiarize with when interested in what influences providers, costs, services, as well as finances of healthcare.
Today we're going to talk a little bit about hospice care. Hospice care is an approach to health care to help relieve the symptoms of terminal illness, and it's not to be confused with palliative care. In palliative care, the patient does not have to be terminally ill. According to the government's Medicare website, hospice is defined as a special way of caring for people who are terminally ill. Hospice involves a team-oriented approach that addresses the medical, physical, social, emotional, and spiritual needs of the patient. Hospice also provides the support to the family's caregiver. The National Hospice and Palliative Organization defines hospice as a patient-centered, cost-effective philosophy of care that utilizes a team of professionals that provides compassionate and expert care pain management, and emotional and spiritual support tailored to the patient's needs and wishes. So why does hospice exist? Well, the concept began as a place of shelter and rest for weary or ill travelers on a long journey. That was until Dame Cicely Saunders referred to the term to dying patients. In 1963, Dame Saunders introduced the idea to the United States via a lecture at Yale University. Saunders created the first hospice in the United Kingdom in 1968, named St. Christopher's Hospice. Frances Wald was the dean of Yale University at the time of Saunders' visit, and Wald was so impressed that she not only invited her to become a member of the faculty, but in 1965, she left Yale to work at St. Christopher's to learn more about hospice care services. Hospice was officially established when Florence Wald, two pediatricians, and chaplain founded Connecticut Hospice in Branford, Connecticut in 1974. Wald was taught by Dame Cicely Saunders from 1968 to 1974. In 1978, the Department of Health, Education, and Welfare reports that the concept of hospice is worthy to be explored and proposed federal support. It was not until 1984 that hospice became an accredited aspect of healthcare by the Joint Commission on Accreditation of Hospitals. In 1983, the Medicare hospice benefit was introduced. And then finally, in 1986, Congress solidified the Medicare hospice benefit, and hospice became available to terminally ill nursing home residents. Now, as a recipient of Medicare Part A, which is hospital insurance, eligibility for hospice care begins. There are three conditions that must be met. First, a physician certification that the patient is terminally ill and will pass within 6 months if the diagnosis runs its course is required. If the patient lives beyond the 6 months, then he or she must be recertified. Second, the patient accepts comfort care as opposed to curative care. And third, the patient must sign a statement choosing hospice instead of treatment. Now, hospice care is based on patient and family plans for end of life. The first step is open and honest conversation for the needs and wants of the patient. Creation of a team including medical doctors, nurses, etc. The hospice doctor and nurse is on call 24 hours, 7 days a week for that patient. It is of the utmost importance that research be conducted on behalf of the patient. So the provider must be certified and licensed by the state and federal government. Medicare will only pay for Medicare-approved providers. So a ratio of patients will determine their level of care. Additionally, the family of the patient should know a few things. Will the hospice staff meet on a regular basis to discuss their care with the family? How does the hospice staff respond to after-hour emergencies? What measures are in place to ensure hospital care quality? And what services do hospital volunteers offer? Are they trained? Just because a patient is in hospice, it does not mean that they cannot receive care for other issues. Family members and caregivers are also eligible for support services such as counseling. Hospice care is for the physical, emotional, social, and spiritual needs of the patient and their loved ones. Furthermore, there are 4 levels of care: routine home care, general inpatient care, continuous care, and respite care. And now my colleague will discuss those other levels of care and provide you additional hospice information.
Put your hands up, everybody know that. Don't hold back, got you on go jack. Go DJ, that's my DJ. Party on replay, party on replay. There's no rewrite.
Today I'm going to be talking about the OIG report and how costs of fraud and abuse affect honest providers. Inappropriate billing has an effect on honest providers. Medicare and Medicaid are stricken all of the time by deceitful people who lie and try to see what they can get from these programs. Medicare fraud happens when people make health claims that are false and receive benefits from it. In doing so, this is found a lot in the hospice care setting. It has been shown that hospices have found improper payments for up to millions of dollars of services not meeting Medicare requirements. And this affects the general inpatient care primarily and costing Medicaid over $268 million. Hospice frequently bills Medicaid for a higher level of care than the beneficiary actually needs or is receiving. Hospices will bill Medicare for things like general inpatient care when that really needs to be provided by a home care provider, or billing for inpatient care when it should only be for like controlled pain and certain things like that. Certain drugs are even getting compensated for through Medicare when hospice should be paying for them. Medicare possibly could be paying for the same services like these drugs twice, and hospice is supposed to provide the information related to these drugs regarding pain and illness, and they're not doing that. Medicare is directly paying for these services provided through Part D twice, and basically it sums up to them paying more than almost $30 million in previous years that should have been covered by Medicare and hospice services. Medicare is really just losing money, in fact, billions and billions of dollars each year, whether it's not receiving what they should or be paying out different amounts to cover things that aren't actually true for their beneficiaries. These fraudulent activities happen all of the time, and there needs to be less of it because it's only hurting the honest providers who are trying to do their job and help the beneficiaries that really need it. Then I go on to talk about the cost of fraud and abuse concerning the actual beneficiary. It affects them and puts their health and well-being at risk. Hospices tend to provide less services than they actually lead on to, and about only 31% that they're claiming. This means that hospice sometimes was unable to provide adequate help to beneficiaries, which resulted in them being in a lot of pain for long periods of time. The OIG investigators have found that hospices are claiming people as their patients, and the beneficiary sometimes has no idea or understanding of what is actually taking place. They are enrolling them when the beneficiary is not actually ill, and billing the health insurance services that have not actually been provided to them, and there are falsified documents to actually prove it. Beneficiaries that are on Medicare have to be careful in selecting the type of care that they need, because when it comes to hospice, they don't know if they're actually going to be getting the services that they say that they are. And they may be inappropriately enrolled into something that they either really don't need or they're being given the wrong type of care. So that kind of wraps up how the cost of fraud affects honest providers like Medicare and Medicaid, and then also how it affects the beneficiary, but there will be more on that later. And also later we will talk about how the cost of fraud and abuse affect the taxpayer. Thanks.
I'm here today to discuss an issue with you that's becoming more prevalent and affects programs like Medicare and Medicaid while affecting taxpayers by raising taxes every year. It is hospice fraud. Hospice is a subject that's dear to me. It is one of my certifications, and it requires a certain level of empathy and compassion to provide competent care for your ailing loved ones while they're in the final stage of life. Hospice is provided 24 hours a day, 7 days a week, but it depends on your level of care, with 95% of care identified as routine home care. 1.4 million beneficiaries received hospice care in 2016, and Medicare paid $16.7 billion in Medicare costs for 1.47 million beneficiaries. On average, hospices providing routine care provided approximately 4.8 hours a week, totaling $1,000 per week in assisted living facilities. There has been an increase in hospice care provision in assisted living facilities since 2007 to 2.1 million people receiving hospice, or 119% in 2012. Inappropriate payments ranging from $447,000 to $1.2 million have been discovered with the reviewing of individual hospices due to lack of required certifications of terminal illness, insufficient clinical documentation, and billing for services not needed or never provided, including inpatient care, estimating a total of $268 billion in 2012. For-profit hospitals provide 48% of general care in comparison to 30% for other organizations. Additionally, for-profit hospitals bill 41% of general in-home care inappropriately, and the stay of patients served by for-profits was on average four weeks longer than nonprofit hospitals, in contrast to other hospices who only bill 27% of care inappropriately. The OIG has taken measures against hospices convicted of fraud schemes that may include, but are not limited to, billing for a higher level of care not needed, billing twice for the same service, physicians not meeting requirements when reviewing hospice certification, and kickbacks. Additionally, drugs prescribed for comfort were supposed to be included and covered by the daily rate of hospice were found to have been charged against Medicare Part D coverage. In 2009, the Office of Inspector General found that Medicare paid more than $30 million for drugs that should have been included in care. Furthermore, the OIG found that Medicare Part D paid for more than 100 drugs used to control symptoms and pain inappropriately. The physician enrolls the beneficiary based on their clinical judgment to determine if the client care is eligible to be covered by Medicare. However, it has been found that in 14% of general inpatient care stays in 2012, the physician failed to reach at least one requirement in certifying care. The OIG has identified nearly $566,000 in questionable claims for provision of hospice patients for physician services in 2009, one in which a physician billed Part A and Part B for the same procedure, physician, and day. The Center for Medicare and Medicaid Services has increased the rate of pay for routine care to 60 days, after which it decreases. Though it's suggested by the Medicare Payment Advisory Commission that beneficiaries in nursing homes should receive a pay reduction. It takes the whole community to eliminate fraud and misappropriation. Providers need to make it a goal to combine integrity with the quality care of patients in order to avoid bad decisions, penalties, and fines.
Through the wild, darkest night is coming. Eyes are breaking time. The ancient drums are pounding.
My name is Afsat, and the topic before me is about our hospice care is related to population health and financial management, with emphasis on providers and costs. Hospice care can benefit terminally ill patients by increasing family satisfaction, reduce future treatments and medical costs. In the United States, hospice care expanded rapidly during the 2000s, thereby improving the quality of care of the patient. While end-of-life medical costs were reduced, the increased cost of hospice itself outpaced the savings and caused higher net Medicare costs. Policymakers have worried that Medicare costs due to hospice care have been increasing, though part of the initial policy motivations was that the growth might save Medicare money by reducing expensive, aggressive end-of-life treatments, such as hospital intensive care. Medicaid, a government health insurance program for low-income households, covered hospice care in most states, while states paying for hospice care are required to provide at least 210 days of care through the program. Eligibility can vary across the country. While private health insurance companies vary in their hospice policies, though many provide some level of health coverage. For instance, Medicare saves nearly $6,430 for each patient enrolled in hospice for 15 to 30 days. And since patients are no longer seeking a cure, it eliminates the costly emergency room visits and treatment that are often associated with a serious illness. Patients who don't have insurance coverage for hospice may find financial assistance through a local organization. Terminally ill patients can receive hospice care in an assisted living facility or nursing home, but they will have to pay for their stay out of pocket. Population health management seeks to control the efforts of healthcare delivery systems, public health agencies, community-based organizations, and many other entities to improve health outcomes in the communities they serve. Providers and policymakers are specifically interested in clinically relevant factors that can improve the quality of a patient's dying experience, mostly factors that are adjustable and agreeable to intervention. Such factors include patient-provider communication, pain and symptom management, medical training and expertise, referrals to hospice or other palliative services, and ensuring the patient goal of care match prescribed treatment. Though dying and death of a loved one is often tough on families, healthcare providers can make a difference. Providers should also be vigilant about tailoring treatment to patient wishes and timely referral to hospice. Medicare programs paid a daily rate to hospice providers. The hospice provider assumes all financial risk for costs and services associated with the care of the patient's terminal illness and related conditions. The hospice provider receives payments for every day a patient is enrolled, regardless of whether the hospice staff visited the patient or otherwise provided services each day. The payment design is intended to encompass not only the cost of visits but also other costs hospice sustains for palliative care and management of the terminal condition and relative on-call services, care planning, drugs, medication equipment, supplies, patient transportation between sites of care that are specific in the plan of care, and short-term hospice inpatient care. Payments are made according to fee schedule that has 4 different levels of care: routine home care, continuous home care, inpatient respite care, and general inpatient care. The 4 levels of care are distinguished by the location and intensity of the services that are provided. Hospice and palliative care have developed effective responses to the needs of populations with life-threatening disease by making the lives of individuals toward the end of life pain-free and dignified, and by supporting their families. Thank you.
Hospice care costs are covered primarily by government organizations such as Medicare and Medicaid. Other organizations such as the Veterans Administration, or VA, and the DoD, Department of Defense, cover certain costs and services incurred by hospice care. Hospice services include nursing care, medical and social work services, physician services, counseling, inpatient care, hospice aid, bereavement services for the family of the patient, as well as speech-language pathology services and physical and occupational services when needed. These services are primarily covered by organizations such as Medicare, Medicaid, and other organizations such as the VA, Veterans Administration, and the DoD, Department of Defense. Other means of funding hospice care costs include private insurance, self-pay, charitable donations, and grants.